So glad you were all able to join us today. We've got a great presentation for you all today. I think it's going to be really relevant to all the work that you're doing. We have with us today Elizabeth Mitchell from the Network for Research and Healthcare Improvement, who's going to talk about their Total Cost of Care project. For those of you who are not familiar with NRHI, it's a national organization that represents 35 member regional health improvement collaboratives. And they're working across regions to transform the healthcare delivery system and achieve the triple aim: improving patient experience and care, including quality and satisfaction, improving the health of populations, and reducing the per capita cost of healthcare. The RHICs, the Regional Health Improvement Collaboratives, are accomplishing transformation through their work directly with physicians and other healthcare providers, provider organizations, commercial and government payers, employers, consumers, and other healthcare-related organizations. So you see that list. It sounds very much like all of you on the phone and all of our partners here at the PCPCC. So again, I know this is going to be great information for everyone on the call today. Just a couple announcements from the PCPCC. Again, hopefully you all received our newsletter today. We've got lots of great information in that newsletter. We call some particular attention to the PCPCC's new strategic plan. So we're excited to share all of that information with you, and please do send that along to your colleagues if they haven't seen that. I think it'll be really helpful, not only for you to learn more about the direction of the Patient-Centered Primary Care Collaborative, but how your organization can help us in achieving that new strategy and plan moving forward. I also want to remind you today that our conference registration is open. Our annual conference is again being held in November in Washington, D.C. Of course, a great, fantastic, impressive lineup of speakers. I think we really are one of the few conferences, national conferences, that happens every year that really does attract all members of the healthcare system, industry, policymakers, patients, consumers. Really, it's everyone coming together and learning from each other. So I encourage you to take advantage of our early bird registration and get signed up for the conference today. We also still have some opportunities left for organizations that want to talk more specifically about their organization and resources and services. We have opportunities for you to do workshops at our conference. We have other sponsorship opportunities, including exhibits that are available. So please do reach out directly to me, Amy Gibson, agibson@pcpcc.org, if you would like more information about having one of those more important roles at our conference. So before we go ahead and kick it over to Elizabeth, I just want to remind everyone, if you haven't been on our national briefings or webinars before, we don't do actual audio question and answer. We ask you all to type in your questions into the question box. Feel free to type your questions or comments at any point during the presentation. And then in the last 15 to 20 minutes of the webinar, I'll be queuing those up and asking those of Elizabeth and her colleagues. So again, go ahead and type in those questions at any point. We will have this webinar, the whole recording of it, along with a copy of the slides, available within 24 hours of the close of the presentation today. So if you have colleagues that were not able to participate on the live call today, please do forward them the link and direct them to go to our website so that they can take advantage of all the great information that we're going to be sharing with you today. So it's now my pleasure to formally introduce Elizabeth Mitchell for our speaker today. Elizabeth Mitchell is President and CEO of the Network for Regional Healthcare Improvement. And Elizabeth will be joined by a few other staff from the Total Cost of Care project at the end of her presentation. A little bit about Elizabeth's background. Prior to her joining NRHI, she served as the CEO of the Maine Health Management Coalition Foundation, where she led many multi-stakeholder payment reform and healthcare redesign efforts. Elizabeth was also selected for an Atlantic Fellowship in Public Policy by the Commonwealth Fund and the British Council. You can find more information about Elizabeth and her background through her bio that's also available on the PCPCC.org website. So without further ado, Elizabeth, I'm going to turn it over to you now.
Thank you so much, and I am really, really pleased to be here. I think NRHI and PCPCC are natural partners with shared aims, and I'm coming to your conference, and I am just really pleased to have the opportunity to talk with all of you and really look forward to questions and engagement. this is really just an opportunity to share one of our projects. I think it is sort of a signature effort, though, that shows the potential of our collective approach. We think of this as cost transparency from the ground up with everybody at the table, so a transparent transparency process. And more than anything, it's about leading change and supporting all of the stakeholders to be successful in a new environment. So we're going to share with you some of our total cost of care pilot findings, but really also talk about how it's working on the ground. So I'm so pleased that Mary Jo and Doug were able to join us, who can share in real life what's happening in their communities as this information is being rolled out, and some of the real life challenges and experiences that they've had over the course of the pilot. As you heard, I am now President and CEO of the Network for Regional Healthcare Improvement. I did, though, as you also heard, run a regional collaborative and build the data and analytics program and led a multi-stakeholder public reporting program. So I understand what this looks like on the ground and the challenges involved. And really want to, again, give huge credit to our members who did this in their communities with all their stakeholders at the table. So today's goals, we really want to share that regional experience about producing and sharing cost data, particularly with physicians. These results were shared more broadly, but our focus was on clinicians and their teams. Also think about what this might mean in the current policy environment with MACRA and the move to change payment, and what this type of data access could enable. And then finally, I'm going to turn it over to Doug and Mary Jo in particular to talk about what next steps are in their communities and what demand is for this type of information and how it's being used. So that's what we're going to try to cover today, and really looking forward to questions about any of this as well. So again, going back to basics, in case not assuming anyone knows what we are, you did hear we are all private nonprofits. We work to improve the quality and value of healthcare with all of these stakeholders at the table. NRHI is the membership organization. We have 30 to 35 members right now around the country, representing about 40% of Americans. And we hope to not only enable the regional work, but also to tie it to national impact and national direction. We are continuing to grow and have significant coverage and lots of engagement across markets. And I really think that one of the important aspects of this pilot was that it was tested in so many different markets. You hear sometimes, well, you can do that in Minnesota, but that doesn't translate. So we really, we love Minnesota, and they were key partners here, but we also tried it in Colorado, in Maine, and Louisiana, in Missouri, and Oregon. So different environments, but really we're able to show that this can be done regardless of some of the market characteristics. But why are we really here today, sort of in an existential type question, is we have a major spending problem. We are struggling to meet the demands of paying for healthcare. I worked closely with large employers for a long time, public and private, struggling to give wage increases, struggling to actually keep jobs. This is really starting to become a very real issue. We all know this, not only for business, but for families. So something has to be done. I think we have all accepted that, but what do we do about it? There are lots of reasons that this is a problem. And I mean, this elephant could have something attributed to every body part, but these are just some of the challenges. And rather than just taking on one of those barriers, like error rates or cost transparency, we're trying to think of a more comprehensive approach. So the way that the collaboratives go about it is really making sure all the stakeholders at the table and are able to play their roles. There's no magic bullet, and no party can fix this alone. So we start by making sure people know where the opportunities to improve are. That varies regionally based on populations, based on markets. So we help with the quality and cost analysis and reporting. We also understand that providers need to change the way care is delivered, whether it's a patient-centered medical home or various delivery system reforms. Those are required to really get to the value that we are seeking. But in order for that to be successful, payment and value cost-based benefit design must be present. We understand that the payment barriers in the current system are inhibiting optimal care delivery. Sometimes we encounter barriers as simple as a copay that is incenting people to use the emergency room instead of their primary care provider, or there is no integrated behavioral and physical health because payment won't support it. So we understand the importance of changing payment to enable that delivery system redesign. And then, of course, patients have to be part of this whole change. Shared decision-making, self-management for chronic illness. We know that all of this has to work together. Everybody has a role to play, and it needs to be aligned and supported by good data, analytics, and effective use of that information. And really, this information is a key missing piece, we find. A patient needs to know where to go for a procedure. Physicians or whoever is referring them need to know the relative cost and quality of the different facilities and providers for that informed referral, or they know the performance relative to different providers or facilities. How do clinicians have this information to be effective partners with their patients as they are trying to navigate the system? Too often that data is not available and that information is not available in a form that enables those shared decisions. So again, going back to the sort of policy context in which we are doing this work, we are increasingly aware of this drive by CMS to change payment. I participate on the guiding committee of the Learning in Action Network. There is a sincere push going on to really change payment, to pilot new ways of doing this. Of course, we are reminding them at every turn that it's one thing to change payment, but is it really enabling the clinical redesign that we have to have? How do we do this in a partnership way? How do we know if it's working? Obviously, MACRA has accelerated that change. We are going to be basing physician payment on performance measures and performance, and all of that will be determined in the next several months, at least for the first round. So this is a very dynamic environment, and understanding cost and understanding variations in cost is only more important as this proceeds. As we know that we are going to have to change practice as well. Lots of CMMI initiatives around TCPI, changing clinical practice at the community and practice level. We understand that transparency is going to be critical for this. There's a growing push for transparency, both at the federal level and, of course, from our private purchaser partners. And then to make any of this work, we have to have shared data. So this is not, please don't take this as an endorsement of the interoperability roadmap. It was really just an indication that the feds are certainly thinking about this. How do we get the data sharing that we need to enable community level change? So where does this all come together? Well, we would argue this happens at the regional level with an infrastructure for improvement, convened around transparent, meaningful, usable data, and assistance to each stakeholder to do their job most effectively. So we believe that this was exemplified in our total cost of care pilot. We were able to select 5 sites who were ready to participate and to do something that, in my view, was totally innovative. The Robert Wood Johnson Foundation funded this project and took a big leap of faith with us. It is 2015 and there is still not cost transparency in any meaningful way, at least to the community, which I find amazing. We've had the Dartmouth Atlas for about 30 years, but we've never had the equivalent type of visibility into variation in commercial costs. So we thought it was very important to test, could we create relatively standard commercial cost, total cost information across these communities to enable change. So our aim was to not only produce that information, which was a big enough lift, but then to actually use that information in the community to enable more cost-effective care. We chose total cost. we talk about squeezing the balloon. Total cost is the proverbial balloon. If we see that we are making a dent in total cost, we know that we are having a real impact. It's not just being shifted to another sector. We selected a common measure, a measure set in this case, total cost and resource use from health partners. We know that no one sets out to create measure chaos and measure cacophony that we have now, but that is what is happening in the field. So we all came to consensus to use a common measure set that we thought would give us not tried and true tested information that would be reliable. And then we really wanted this to be actionable. It's one thing to have a report on your performance and say, wow, you're expensive or you're not. One thing that was so appealing about this measure set is that it includes resource utilization. And so that when you go to a provider or a practice, you can say, well, here's where you rate relative to your peers in terms of total cost, but these are some of the reasons. We are seeing these utilization patterns, and this is how they vary. Again, this is not the sole source of information. It is an indicator, and we have found that it is valued by most of the folks we're working with as at least a directional signal that they can use to really understand variation in cost. So as I said, we selected the NQF endorsed measure set. It had 20 years of testing behind it from health partners. It was, as I said, NQF endorsed, so there was every reason to be able to stand behind its credibility and validity. We wanted to take that much off the table and start with a really reliable measure set. And then we really wanted to make sure it was implemented in a standard way so that you could get some comparisons and understand what created variation. That meant that we did what we could to align attribution methods. We did not get to complete consensus, but we moved towards similar attribution. And we tested the same risk adjuster because we didn't want that to create undue variation. So most of our partners kept their own risk adjusters, and we all tested a common risk adjuster. We learned a lot about the impact of risk adjustment on some of these results. But again, it was a bigger project looking at, can you produce this common measure across communities attributed to the practice level? We were able to identify some best practice in cost information sharing. Not everybody was really excited about this project. There were plenty of people who would have been just as happy not to get this information. But I will, give enormous credit and thanks to our members who worked through those local processes of engagement and explaining what is in the data, what is in the measure set, what does this actually tell you and what does it not, and taking input back from their stakeholders. How could we make this more meaningful to you? How can we explain this in a way that actually creates a tool that you find valuable? Huge engagement process to really help people understand what the measure does and does not do and why it's helpful. So again, bringing those stakeholders to the table from the beginning is a key part of our process of transparency, and we found it to be incredibly important as we move forward here. And a little delay, I just wanted to also mention that we are in addition to the 5 sites that were our fearless leaders in phase 1, we have also now expanded to phase 2 with, again, thanks to the Robert Wood Johnson Foundation, and Health Insight Utah and the Maryland Healthcare Commission will also be producing this information in phase 2. And another test we are able to explore at this point is also bringing in a state agency. So it's one thing for regional collaboratives to do this. Now we're expanding to understand if this can work from a state agency, and we want to always thank our technical advisors and our funders. So what are some of the lessons learned here? What were some of the scars that we have that we can share with you? It was critical to start with a common vision and aligned mission to bring the stakeholders at the community level together and to get commitment early and often. There are more bumps in this road than you can anticipate, and to really bring it back to your stakeholders, say what you're learning, what the barriers are, what the challenges are, and to keep that engagement alive and well has been really critical for this. And it has to be locally tailored. Not everybody produced the same reports. or shared them with the same stakeholders or through the same forums, but they were all neutral forums with trusted data. I really want to emphasize here as well that all of the sites that are participating were eligible to do this work because they had access to multi-payer claims data with the complete cost fields. And that may sound like a low threshold, but I can assure you it is not. To actually have the voluntary participation of all of the regional health plans in submitting this data for use was a key factor in enabling this work. And because of the way the measure set is reported, it is very sensitive to not revealing any sort of proprietary information. It creates an index for cost. So we feel that that has really demonstrated the utility and value of having this combined multi-payer data for this type of work. And again, from the physician and practice perspective, you're not just looking at one payer's results, you're looking at total cost across commercial payers. So what did we achieve? Well, we did actually, well, we, meaning the sites, our members, were actually able to produce and distribute attributed practice level reports in their respective communities. That is a huge achievement. And I will, certainly invite Doug and Mary Jo to share a bit more about that. We did design a benchmarking approach across the 5 regions, and that was much harder than I think we anticipated. And we had a very high bar technical advisor who actually did not feel that we had reached the level of reliability to actually generate reports using a benchmark. So while we did test different methods, we did not actually report a benchmark. That we will continue that work in phase 2. But we did make huge progress in understanding the variation and some of the drivers of this variation. And we shared with community stakeholders. And then really importantly, we worked with participating physicians to lead change locally. And I'm going to shift gears a bit and talk about one aspect of the project, which I'm going to actually, we can skip forward just a little bit, Kelly, but before we talk about where the physician leadership seminar, which is really something I want to make sure we get to, these are just examples of some of the resource utilization reports. Sorry, we're just skipping around a little bit here, of what was received by a practice as an example. This was in Maine. You see the smaller shot, it was part of an overall practice report on various quality and utilization measures, and then they could drill down a little bit into their resource utilization. There are certainly drill down options, but this was sort of a high-level summary report, what a practice might receive. I would also say, at least in Maine, and this was done differently in the different sites, each practice in Maine was able to receive a free report subsidized by the SIM grant. So there were lots of different methods of distribution, different approaches to funding some of this work. But this was, again, I just wanted to share an example of what it looked like. And it differed in the different sites, and we are certainly happy to share different examples and different approaches. Again, continuing just a bit further with the key lessons learned, know your data. The data quality is critical. Some of our participants would say every time we publish a report, our entire organizational reputation is on the line. We cannot publish bad data. And the commitment at each site to make sure that this data was correct and valid was just remarkable. And it really earns them the credibility and trust of their stakeholders. Assume nothing. We thought certain cost drivers would exist, didn't pan out that way, and you really have to test the data. You've got to go back and say, am I reading this right? Really do the heavy intellectual lift of challenging your own assumptions. Don't go it alone. Work across peers. Learn from each other. As again, using Maine as an example, they had about a year's head start in talking with physicians. They were able to share some of that experience with the other sites. Minnesota had a great way of working with their health plans and had done a lot of this work before joining the pilot, they could share some of their technical experience. Just as examples, we shared that across sites. Again, engage stakeholders, and then really keep in mind the use of the data, understanding that it is not perfect. In our booklet that you just saw a screenshot of a few minutes ago, there are some stories from each of our sites. These are some of our leads from each site: Michael De Lorenzo, Jonathan Matthew, Meredith Tomasi, and Mary Jo Condon. Each of them tell their story about what they learned. In the interest of time, I think we will just offer you that booklet if you want to really hear their stories. Because we do have just a few minutes left, I want to talk particularly about the physician leadership aspect of this. So we talked directly with physicians. We identified physician leaders in each community and invited them to come to a forum at Stanford that was led by Dr. Arnie Milstein and then several of our consultants and partners to really understand what are the barriers they face in their community when they get data that they actually do trust and want to use. What are some of the barriers about being leaders in driving change? You know, do they have to be always the skunk at the garden party saying, well, guess what, you're too expensive? You know, what are some skills and techniques and strategies that work in organizing peers around using data to change practice, to change culture? And there was, this was a tall order. We had folks coming from all over the country to get together for a couple days, but we really, I think, got amazing engagement, folks really starting to understand the value in partnership, and really recognizing their role supporting physicians, supporting patients who are increasingly bearing more cost for their care. They want to know, where should I go if this is what I'm going to have to pay? And recognizing that they can be their advocates when they have this information. So just a lot of receptivity to this information and to this role, and that we were really pleased to support. We really wanted to make sure that we were able to share with them real data, so it wasn't theoretical, and to talk about what your role is as an ambassador for change. How can you be a physician champion? And that ranged from everything from, you know, what are the motivators to what are the barriers, and really offering also peer support, leaving that forum. How can we help continue this and let us continue to be resources for you as you continue on this journey of managing cost. We really wanted to make sure that it was supportive and really enabling them to meet the barriers that they would face. We also did a lot, we asked a lot of them too. We had them really come prepared to address specific issues in their specific communities. All right, Kelly, keep going. We really, again, wanted to also explain why total cost was so important and why it was actually a responsibility of local physicians to take this on. And then this is just an example of, we not only did this at a national level, we then piloted it in Minnesota to do a regional level. And we really set it up so that it wasn't just sort of, you know, we'll take you out of your community to come to a conference, but really coming to you and helping you understand what it would look like in your region. And again, we found just huge receptivity to it and lots of demand for this type of information. So it was a key part of our success, a key part of moving this forward. It's one thing to produce data, but if no one uses it, what have you really accomplished? So it's about engaging the leaders in the field to have the tools that they need to make change. And we really believe that we were able to at least contribute somewhat to that. So our next sort of steps in phase 2, now that we're seeing that there has been uptake and support and interest, we are going to be orienting ourselves to even not only expanding the sites that are participating, but expanding the data. So many of our members who are participating are qualified entities, which means that they have the identified Medicare data. We are working closely with CMS to understand if and how we can include Medicare data in our reporting, so to get a true all-payer view. Again, no one practices by payer. You need to see the full view. And you know, Oregon, and Doug might be able to comment on this, was again a pioneer on reporting using Medicare data through the QE program, and saw a big impact on their results when it incorporated non-commercial data. So using all payer data will be a big focus of our next phase. And we also know that CMS is very interested in total cost as part of payment reform initiatives and macro rollout. But as we understand more and more clearly, that information is very rarely available. And when it is available, many practices or clinicians don't know what they can do about it. It is too removed from their day-to-day practice. So if they are suddenly held accountable or put at risk for total cost of care without given any visibility into what is driving the relative cost, it's really not enabling positive change, and honestly is probably just more frustrating than anything else. So how do we make sure that the resource utilization information is there, it's consistent, it's across payers for a population view, and it rolls up to total cost? So we will be working to make sure that this work is as aligned as possible with the direction of MIPS and the alternative payment models, and really thinking about some of the other aligned performance measures. So it's not just cost. We all know that. No one's interested in just the cost. What are some of the complementary quality measures or patient experience measures that might give a complete picture of care? So that, again, is sort of future work, at least integrating the quality into the cost. But the cost information, in our experience, was totally absent otherwise. And we just felt it was too important not to take on because we can't address the cost issue without cost information. And we really wanted it to be done in a way that was empowering to physicians and empowering to all of the clinical team so that they could actually do something about it. With that, I would like to introduce Mary Jo Condon and Doug Rupp, who really did the heavy lifting on this in their respective communities, to either contradict anything I said or to add to it, but particularly to really share some of the color and the story of what's happening in their communities as this information has been rolled out. So they've done the big work of producing the information and working with stakeholders. And so, Mary Jo, could I just ask you to share for just a few minutes what's happening as this is rolled out in Missouri?
Absolutely, Elizabeth. Thanks for your leadership and the leadership of NRHI. This has been an incredibly fun and worthwhile project for us to work on. What's happening in Missouri? So, you know, we have focused our reporting on the St. Louis region, and we've been out to meet with medical groups that care for about 50% of patients who regularly see a primary care physician. And in talking with those groups, we've had some really incredible conversations, sharing their results with them, showing how they look compared to their peers in the community, and also sharing some preliminary information about the project as a whole and the National Physician Leadership Seminar, which was a great experience for us as well. You know, in talking with the groups, I think the story for each group is as unique as the story for each community. And so one of the things that we tried to do was really tailor those presentations to the successes of that group where they looked really good, and also some areas of opportunity. So for one group, for example, you know, they're just getting killed on high-cost drugs and specialty medications. Their group, although they're primary care physicians, the same group has a lot of specialty care that is in areas where there's a lot of high-cost medications, such as oncology and gastroenterology, dermatology, and now increasingly hepatology. And so we had a really great conversation with them about that. That was actually the group that has the highest generic prescribing rate of any in our community, and yet they're still getting killed on pharmacy costs. For another group, they had some area of opportunity around imaging. And during that meeting, a physician spoke up and said, you know, I have to say that, and turned to the leader of the medical group and said, in part, you pay me based on patient experience, and some of the patient experience measures I feel reward me when I image if that's what the patient wants. And then another physician spoke up and said, well, you know what, I really think it's our job as a physician to make sure that a patient leaves our encounter knowing why the image wasn't necessary and making a joint decision that that's the right decision. So we've been able to listen in on some really amazing conversations, and we're going to be having a meeting in September to share some of these results more broadly with our community and really think about how do we as a community become a national leader in health and care quality and affordability. And until this project and the ability to work together with the other communities to apply this measure to our data set, we really didn't have that affordability piece. And we've heard not only from employers and consumers about how important it is, but also from physicians who are increasingly interested in the cost of health care and its role in their patients' health.
Thank you, Mary Jo. And Doug, can I turn it over to you now to share what's happening in Oregon as well?
Sure. I'm Doug Rupp. I'm an analyst here in Oregon with the collaborative here. In Oregon, we've released 150 practice-level reports for adult and pediatric populations. And the reports include quality, utilization, as well as the cost measures. They break out inpatient, outpatient, pharmacy, as well as the professional costs, including what happens in the PC office and PCP office and what happens at specialists. As Elizabeth mentioned, our data comes from multiple health plans, which gives a practice a broad view of their patient population. And we've really found that that is valuable to practices. The work that we did was not done alone. We got a lot of support from NRHI and the other RHICs, which made the work that we did, I think, much more valuable. We also here in Oregon had a multi-stakeholder steering committee that really guided the reports and I think helped get us get reports out that were really valuable to clinics. As Mary Jo said, each report tells a different story, and we're finding that practices know best what's important in these reports, and many times we'll dig into their EMR systems to confirm what's happening and then help guide change in their practices. We're seeing practices find things that provoke questions like, why are our multi-source brand prescription costs higher than the state average? And they're also helping practices confirm things that they're doing right, that they have initiatives around, like lower ED visits. And we had one clinic group that was very happy to see their resource use was high in behavioral health, because that's one of the things that they're really working on. As we look forward during the next round of this project, we will be releasing reports twice a year, and we'll be looking at the variation in reports year over year. As well as Elizabeth mentioned, we'll be looking into expanding reports to Medicaid and Medicare and what that would be involved with. And here in Oregon, we're hoping to be able to report also on the Medicare fee-for-service data that we have through the Qualified Entity Program. And we will continue to meet with our multi-stakeholder steering committee. They've been incredibly valuable so far, and we're really looking to them to help us understand how to continue to make these reports actionable. And as Elizabeth mentioned, there are 2 more RHICs in the group, and we're really excited to be able to pass along the knowledge that we've learned in this project as we've gained it.
Thank you, Doug, and thank you, Mary Jo. I just really want to emphasize, even though NRHI could provide sort of coordination and leadership, there is incredible work at the regional level that actually makes this happen. And not only are they sophisticated and skilled users of data, but also skilled collaborative leaders that keep people together through tense sometimes and complex change. So cannot emphasize enough the importance of this being done regionally across sort of trusted forums. So thank you all. And with that, I guess we can open it up to questions.
Fantastic. Elizabeth and Mary Jo and Doug, incredible information, incredible work that you're doing. I can't emphasize enough what you were talking about, Elizabeth, is that we cannot start to really drive much of the change we're looking for as it relates to cost of care if we don't have more of this data and information at hand. And just to, as a quick question, before we get started going through the list, I did see that people are looking for, if you have any places, maybe, Elizabeth, on your website, does the public have access to many of these reports that were discussed for the regions that are being used for this data, or are there places where people can go? Do they need to go to the individual regions to find this information? Can you let people know where they can get some more of this data?
Certainly. We do have a summary of our pilot findings that is available on our website. We actually have some video footage from the Physician Leadership Seminar and our summit in DC a couple months ago. And there are also some examples of the reports. But if you look at that website right there, please feel free to contact either me or Kelly or Ellen Gagnon, and we would be happy to direct you to these resources.
Great. Just a quick reminder to everyone, again, if you would like to ask a question or provide a comment maybe about some of the work that you're doing on this front in your community, please do go ahead and type those questions and comments into the question box, and I will queue them up for our speakers. Again, while we're waiting for some more questions to roll in, and Elizabeth, if you could speak to, so we heard a lot about how clinicians are using this data, both in terms of discussing amongst clinicians across the region about what some of the issues might be, and even somewhat to the practice level. Are there any efforts going on in these regions to communicate this information more broadly to consumers and patients and kind of bring them into the partnership to have them really help think through some strategies and some solutions to improving on the cost front?
That is a great question, and it is something that we discussed with Robert Johnson at great length, sort of as this project evolved. It is absolutely intended to be publicly available at the community level, but our thinking, at least initially, is that this is not the most consumer-friendly measure set. It does not give you the estimated price of a procedure based on your, benefit design, and it's not intended to do that. So while we do have some regions who are working to include this in their public reporting, maybe as a 3 or 4 star rating on responsible resource use, it is complex to translate to a consumer audience sometimes, sort of a total cost index. So our initial focus was, again, working with physicians in phase 1. We also are starting to work with employers. How do you use this information in payment reform? We actually have another paper on using total cost of care data for payment reform that we're happy to make available. And I actually would ask Mary Jo if she could talk a bit about some of the employer engagement in Missouri, if you don't mind, Mary Jo.
No, happy to. So the Midwest Health Initiative St. Louis's Regional Health Improvement Collaborative, was founded in part by the St. Louis Area Business Health Coalition, which is an employer collaborative that has been in place for about 30 years and brings together more than 50 leading St. Louis-based employers all around how to improve the health of their employees and their families and improve the value of their investments in health benefits. And so with that as their mission and MHI as their offspring, as you might expect, they are very interested in this project, and they've been following it closely. They have seen the results on a blinded basis, and they are eager at some point to have for the data to be in a place where we can share it more publicly with them and with their employees. I say that because we feel it's really important as part of a collaborative multi-stakeholder process to make sure that we've had an opportunity for everyone to get comfortable with the data, ask us questions, help us refine the risk adjustment methodologies, the attribution methodologies, all the components that really help make the data not only fair but also actionable before releasing it to the public. And so we're a little bit earlier in this process than some of the other communities, but we are making progress. We are going to be participating in the second round and hope to, soon after that, have public data available. But I think that it's really been important not only to MHI but also to the employers to make sure that we're really vetting the data, kicking the tires as much as we can before making it available to consumers.
And I would also add that, thank you, Mary Jo, that we know in Oregon and Minnesota they are beginning to bring consumers in to test how you might share this effectively in their community. Doug, I don't mean to put you on the spot, but don't know if there's been, if you've learned anything about that yet or if that's just getting underway.
Sorry. Yeah, here in Oregon, we've also worked with the multi-stakeholder group, and we'll be looking to that group to inform us on how we'll be presenting this to other audiences.
Great, thank you.
So another question that, just to get a little more specific on, you talked about the risk adjustment. Could you speak a little bit more to what goes into that? And more specifically, we've got a question around what types of characteristics, if any, are you tracking around the population in terms of functional status, economic status, health beliefs, and illness burden. This is often data that's very hard to capture, but I don't know if any of the regions or you've considered any of those different data points.
Well, I am going to turn the question over to Doug and Mary Jo in a second. But I do want to just say that this was these measures are generated from claims data. So we are using claims data as our source of information here, and with its inherent limitations, but also looking to make it valuable. That said, several communities are also publicly reporting different quality or patient experience metrics, and even in some cases like Minnesota, patient-reported outcomes. But those are separate data sources, obviously, and are being combined in different ways. But this is really produced from claims data. But Doug, do you want to add to that?
Sure. I just was going to say the risk adjustment methodology uses the Johns Hopkins ACGs, which take into account diagnosis, gender, and age only. And we have had discussions, particularly at the physician seminar that Elizabeth mentioned. We've had discussions about taking into account all these other factors of socioeconomic levels and access factors, and those things are, we're seeing them come out in the reports here in Oregon as variations. So we are not risk adjusting those out, but we are seeing those things have an effect on the care that people are getting.
This is Mary Jo. The only thing I'll add is that, there's risk adjustment is complex, so complex. And so we are going to be testing another risk adjuster as well through the next process. We're going to be testing the Optum products. The other thing I'll mention is that we're also trying to look within some of our large medical groups that have practices in communities with different socioeconomic circumstances to see whether or not communities that are more disadvantaged tend to have higher costs. I think that work right now is very early, and as we add public payers to the mix, it'll be more interesting. Right now we're also dealing exclusively with commercial data, and so there is some additional layers that will be added as we add some public sources of data.
Fantastic. So again, I think, Elizabeth, you already spoke to this, but maybe in terms of that future direction too, talk a little bit more about how the total cost of care impact value-based contracts when those are in place. Because again, that whole issue that claims data is a good source of information, but it has its limitations. When we start to talk with clinicians about attributing, improvements in quality of care and patient satisfaction, can you speak a little bit more to that issue?
I can, but I will go beyond the scope of this project potentially.
That's fine.
What I would say, and this is partly my personal view, but I believe we need a mix of not only cost and utilization information, probably based on claims, but also quality outcomes that is best generated from clinical data, and patient experience and patient-reported outcomes. So it is a multi-source solution, multi-data source solution. That data is not easily accessed in any sort of standard way. I will tell you, NRHI is leading something called the Center for Healthcare Transparency. That's another of our initiatives that is looking to figure out sort of the ways to make that data most effectively available for all of the stakeholders in a responsible way. But that is very future-oriented. To the extent that there will be performance metrics for MIPS and APMs coming out of MACRA, I apologize for all those acronyms, but for the alternative payment models, we really hope that they do use more ambitious, high-value measures that are more oriented towards outcomes. That will be challenged by limitations on data access. So this project, we believe, fills a major and important gap in cost and utilization information, but it must be complemented with clinical outcomes and patient-reported outcomes and patient experience of care, which will have to come from other data sources.
Absolutely, and I think this is an area where, again, you brought this issue up that, giving part of the data is helpful to an extent, but we have clinicians out there who are getting really concerned about what their ability is to really impact those overall costs, and especially when you tie that into, how much do the patients understand where these cost drivers lie, how much impact they have, and then, of course, considering their out-of-pocket costs. I don't know if you've also looked at across your regions, because clearly there's some diversity as it relates to access to healthcare services. So kind of going back to, the Dartmouth Atlas and a lot of other data that's come out more recently about, regions where there are lots of healthcare services available, their costs are higher. And in some rural communities, they don't have the access to those types of specialty services might not be as great, but it doesn't necessarily tie in to the overall quality of care, or it's not a direct correlation to that. Can you speak to the regions that you're working with and some of the data that has come to light as it relates to access to services, if at all?
I can't very well, but I would certainly invite Mary Jo or Doug to comment. We know this is an issue, and we have several members who are working in their communities to test all sorts of different models, layperson models in the communities to do care coordination, to work across sites and clinics, and there is a lot of work being done. I don't know that we have data to really explore the impact of access limitations, but Mary Jo or Doug, do you have insights on that?
Not specifically, no. The only thing I would say is that, just as the data collaboratives around the country grow and build and gain more sophistication with their data, I think that each of us are seeing a lot of the big trends in healthcare that we've all known anecdotally. And so, for example, being able to watch the primary care setting in many ways move to a retail clinic or to an urgent care office or to extended hours. So although this project isn't specifically around access, I think that as all of us just get deeper and deeper into our data sets, we're able to analyze a lot of the offshoots of the access problem.
Great. Doug, did you have anything you wanted to add to that at all, or no?
Well, here in Oregon, we've got some very rural places that that access is an issue, as well as many other reasons. So it's definitely something we do want to look at, and I think that this cost information can shed some light on it. But we're as Elizabeth and Mary Jo said, we're at the very beginning.
There are plenty of
clearly
problems
we have.
to solve.
Oh, go ahead.
I just said there are plenty of problems to solve, and
exactly.
we really look to partnerships.
Yeah. Clearly we have a lot of work ahead of us, and this is an area that we're really excited at the PCPCC, Elizabeth, as you mentioned, to be working closely with your organization and all of your efforts, especially as we tie into the amount of resources and impact that we're seeing around primary care access, and as we're trying to change care delivery and redesign in primary care and integrate behavioral health and oral health and all of these other aspects and driving more of that to the patient-centered medical home. We're really excited to be working with you on that front as we figure out the best way to map all this out in a way that makes sense for patients and for clinicians, as they're both going to be working to help make improvements on this front. So again, I know we're at the top of the hour. I do want to remind everyone that we will have a copy of the slides and the presentation available on our website by the end of the day tomorrow. Thank you so much, Elizabeth and Mary Jo and Doug and Kelly, for helping us out and giving a fabulous presentation today. Again, lots more to come, lots more information and work that's being done on this front. So I just want to thank you all for your efforts, and we look forward to working with you in the future. Thanks again, everyone.
Thank you.
Thank you.
Thanks.
Bye-bye.